So welcome everybody. So I am Sue Hookey and this is the National Lung Cancer Screening Program. Fabulous to have you all here. And many of us are asking what's involved and how do I prepare? So this is what we're going to learn more about today. And next slide, please, Olivia. So I'd like to acknowledge the country that we're on. So Northwest Melbourne Primary Health Network is on the lands of the Wurundjeri Woiwurrung people and the Boonwurrung people and the Wathaurong people. So we pay respects to elders past, present and emerging, as well as to any Aboriginal and Torres Strait Islander people who are here in the session with us today. Welcome. And this is a Zoom meeting. So just wanting to encourage you to keep your microphone on mute and just check it every now and again, especially if you're going to speak, just check it's on mute. We are using the chat box today. So this is easy to use just in the chat box. We are recording it. So if you want to look over something again or share it with other people in your practice, let them know it's being recorded. And make sure that you actually have your correct name on your Zoom box so we can actually register you and give you your CPD points and mark your attendance. So if we haven't got the right name, so if you're not familiar with changing your name in a Zoom meeting, click on where it says participants, or if you're on your app, you click on your name. So there's a little section that has little dots. So if you can do that, go over to where the little dots are and it says rename. And it's really important that you can do that with your new name, and you can either remember it for future meetings, but you need your first name, last name, so that we can actually check that it is you and give you your CPD points. So we can't have it, it's, Zoe's iPad or something like that. We really need to have your full name, please. Next slide. So just more formally to introduce myself, I'm Dr. Sue Hookey. I'm a GP. I work at Royal Melbourne Hospital as GP liaison. So I get the privilege of being a GP working in the hospital at that critical space between the hospital and the community. And I get to speak with a lot of the people in the hospital, helping handover and helping things to move more smoothly with our patients going in and out of the hospital. I also work as a medical educator with the RACGP training program in northwestern Victoria. So you might see me around in some of those spaces. Today we are going to be doing the poll questions. So in a few minutes we'll be doing some polls just to get an idea of what you already know. And then we'll be getting all the information about the screening program. Then we'll be moving on to how your practices can use tools to identify patients by age and smoking status to see if they're eligible for the lung screening program. Then we're going to be looking at what are some of the services, pathways and information that will be relevant if you do find cases in the northwestern Melbourne catchment area. Then we'll be looking at how Health Pathways is your friend, how Health Pathways can help you with the referral, where to refer your patients and how to navigate this lung cancer screening space. Then we'll wind up with a few more questions on a poll to see how things are after you've got the information. Then we have a decent amount of time for question and answers. So write your questions down as we go in the chat or grab a piece of paper and bring them up. You're welcome to unmute and speak at that end, or ones that are being put in through the chat, I'll bring those up later. So welcome everybody, and we will hand over now to Asha. So Asha works at the Royal Melbourne Hospital with me. Asha Bonney is a respiratory and sleep physician, and she's also a lecturer at University of Melbourne and a respiratory and sleep physician at Eastern Health, a member of the Thoracic Society of Australia and New Zealand Lung Cancer Working Party, and she's recently completed a PhD in the field of lung cancer screening and is the clinical lead of the Lung Nodule Clinic at Royal Melbourne Hospital and lead of the Lung Nodule and Screening Program at Royal Melbourne. And we are really delighted to have her sharing her knowledge of this area with us tonight. So thank you, and over to you, Asha.
Thanks, Sue, and thanks for the introduction, and thanks for everyone for joining tonight. So we just wanted to start with some pre-presentation poll questions. So I think Olivia's going to bring those up, and we're just going to have about 5 minutes just to answer those questions on your screen, if you could.
And you might need to scroll down. So just be aware you might need to scroll down. There are 5 questions. So we have a couple of people who haven't participated, so we might be just about at the end of those who are doing it.
Maybe we'll end it shortly. Do I just click something? Great, I think that's that finished, Olivia.
Yep, that's finished.
Brilliant. Thanks, everyone. So that's really helpful for us in terms of making sure that we're getting the right content, and we'll do another poll at the end of the talks. So I might take over screen sharing if that's all right. All right, so that should be sharing now. So with this first talk, what I really wanted to do is just talk about our National Lung Cancer Screening Program. And in the first instance, just briefly go through the evidence and then discuss the first part of the screening program, so that eligibility and recruitment process. So I suspect most people in the audience are aware that lung cancer is the 5th most commonly diagnosed cancer in Australia, but it's the leading cause of cancer-related deaths. And that's true for Australia, but also globally. And it's particularly true for Indigenous patients who have lung cancer twice as commonly detected and have twice as many deaths related to lung cancer. So why do we screen? Well, when we look at the stage at which lung cancer is diagnosed, just under half of lung cancers are diagnosed at stage 4 when it's metastatic disease. Now, when we look at the 5-year survival for lung cancer, overall, it's just over 20%. 5-year survival for lung cancer, it's about 11% for First Nations patients. But when we look at it by stage of diagnosis, if you're diagnosed with stage 1 lung cancer, you're sitting at about 68% 5-year survival. And that's compared to 3% if you're diagnosed with stage 4. And so the purpose of screening is really to detect lung cancer early, when it's asymptomatic, when it's stage 1 disease, and when it's potentially curable. So how do we screen? Well, this is just two examples of screening modalities that have been investigated in the past, and perhaps it's a bit obvious to have them side by side. You can see on the left is a chest X-ray, which in previous studies did not show any evidence of mortality benefit with lung cancer screening. And on the right, we have a low-dose CT scan, which is much more sensitive and has shown promise, which we're going to discuss in studies that have been published over the last decade. Other tests that have been studied are sputum cytology, which haven't shown any evidence to help with the detection of lung cancer screening, as well as biomarkers, which are currently under investigation. So these are two of the biggest trials in lung cancer screening. So the first one here is the American National Lung Screening Trial. And this was the first study to really demonstrate a mortality benefit favouring lung cancer screening with low-dose CT. So this was published back in 2011, and it compared low-dose CT to chest X-ray. This was followed almost a decade later by the Dutch-Belgian Nelson study, which compared low-dose CT screening with no screening, and again demonstrated a reduction in lung cancer-related mortality. So we actually did a systematic review looking at randomized controlled trials and their impact of lung cancer screening with low-dose CT on lung cancer-related mortality. And you can see here, ABERLY is the NLST trial, DECONING is the Nelson study, and we have other randomized controlled trials which were conducted in Europe and the US. And overall, there was a 21% reduction in lung cancer-related mortality. It's important to note that these studies really did have quite a homogenous population. So it was people who were high risk with a significant active tobacco smoking history that were included in these trials. We also found that there was a reduction in all-cause mortality of about 5% across the studies. And so on the back of all of this evidence, back in 2023, the Australian government actually announced funding a national lung cancer screening program, which is due to commence this year in July. And of note, they did highlight our First Nations patients as a priority population for the lung cancer screening program. So the eligibility for our lung cancer screening program, which is a biannual, so CT every 2-year program, is pretty narrow. So it's for people aged 50 to 70 who are asymptomatic, who have a history of active tobacco smoking. And if they have quit tobacco smoking, it needs to be in the past 10 years. They also need to have a substantial pack year smoking history of at least 30 years. Now, I know we all know how to calculate pack year smoking history. It is not a precise it's an estimate. And so really looking at when this person started, when did they stop smoking, what was the most that they smoked, to get yourself an average, with 1 pack being 20 cigarettes. This does not apply to vaping. So the eligibility criteria is specifically about tobacco and cigarette smoking. So when we look at the program entry, so this is a simplified diagram. The government really envisages 4 ways of patients coming into screening. One is if there's any organised invitation, so through your primary care practice, if you invite patients who fall within that 50 to 70 age range who have any smoking history to then come in for assessment for eligibility. The other way is opportunistic, so you happen to be seeing them for another reason and note that they might be eligible for screening. They are also encouraging other healthcare providers, specifically Quitline, to advise patients of when they may be eligible for lung cancer screening and refer them into their primary healthcare provider. Or you may also get patients who self-identify and approach the clinic for lung cancer screening. And essentially, any healthcare provider can really assess for eligibility, can offer smoking cessation support. There is also a role in shared decision-making and making that informed choice to enrol in lung cancer screening and also then sign up to the National Cancer Screening Register. But where the requesting practitioner really comes in is across all of these to confirm the eligibility and also to check the suitability of this person enrolling in screening. The practitioner is also the only person who can actually request a low-dose CT test. So in terms of the requirements prior to screening, so eligibility is only assessed at the baseline. So if you have a patient, for instance, who has quit at 9 years and you assess them as eligible, then in 2 years' time, when they quit 11 years ago, that's irrelevant. Once they're in the program, they will stay in there until they hit the upper age limit. But however, every request, you need to check for the suitability to continue with low-dose CT screening, have that shared decision-making. The registration is also once off, but as I mentioned, each time you refer a patient in to get a screen, they will need to see yourself and then have that request done. So I just wanted to discuss the cost. So when it came to the 264 million that was funded by the federal government, that really is for so far only 2 mandatory bulk billing MBS items, and that's for the CT scans. So it is presumed that the bulk of screening will occur through private radiology providers. However, if they are participating in screening, they do need to agree that they will bulk bill patients for their CT scans. And there is one MBS item, which will be for the baseline and the 2 yearly routine CT scans. And then there will be a second item for any interval follow-up scans that may be required during that 2-year period. And that's not specific to any interval. It could be the 3-month, the 6-month or 12-month. What's important to note is that there is no additional funding that's been announced for additional item numbers for the actual eligibility assessments and follow-up reviews. And so the government has made it clear in their advertising that of some patients, if they do not see a healthcare provider who bulk bills, that there may be a general fee associated with consultations for screening. So where Victoria is still in development in terms of a centralised list of which radiology providers will be signing up to offer lung cancer screening. I suspect it's going to be closer to the date of screening when that's available to us. There will be, however, a universal screening referral form, which includes the relevant information, and that includes family history of lung cancer, because that's important in terms of determining the risk of particular screening findings and subsequent management. But this I borrowed from the South Australian Department of Health presentation, where they were talking about their mapping of availability for CT screening. And you can see here they've identified relevant private and public clinics that will be offering screening services. The Australian government has also commissioned 5 Heart of Australia CT vans, which will be travelling to rural and remote communities to offer screening to patients who do not have access to a CT scan locally. But this is a bit of a watch this space in terms of finding out exactly which radiology providers will offer it. So I might break there in the presentation. We'll talk about the subsequent findings and positive results of screening, but I'll hand over to the next speaker.
Thanks, Dr. Bonnie. I think that's myself. Evening, everybody. My name's Phil Flanagan. I'm a Quality Improvement Officer, a Programme Officer working at the North West Melbourne Primary Health Network. And I'd just like to talk about some of the practicalities of how practices can go about identifying patients by age and smoking status in line with the eligibility criteria. So as Dr. Bonnie has advised, we've got some new eligibility criteria for the lung cancer screening program starting on the 1st of January. And I've said it's versus PenCat. I'm going to talk about PenCat, a little bit about best practice and medical director. And I just wanted to reiterate, as we've heard, that for the new program, we're really looking for people who are aged between 50 and 70. They're asymptomatic. They don't show any signs of lung cancer. And as Dr. Bonnie said, they have that history of at least 30 years pack smoking. And they also maybe have 30-year history, but they've quit within the past 10 years. Now, the interesting thing to think about in relation to the software that you may be using in your practice, PenCat, BP, or MD, we cannot currently completely filter the patients directly in the same way as the new eligibility criteria for the lung cancer screening program. So what we can do is we can, in PenCat, for example, we can look at the age range. So in this case, that would be patients between 50 and 70. We can obviously look at smoking status, but we cannot calculate a history of pack years, whether people are still smoking, and we can't calculate the pack year history if they've actually quit smoking in the last 10 years. Thank you. So just in terms of the pack years, we've heard that smoking pack years are calculated in relation to the number of packs that you've smoked per day for the number of years. So 1 pack a day for 1 year would be 1 year, 30 packs a day for 30 years would be 30 years, and so on. And we've also identified that we don't currently have any pack year calculators in the software that's generally used in general practice. But I should point out that there are a number of good ones online. There's a couple of examples that we've just included there. The one that comes up very easily is MD Calc and Should I Screen? And essentially, as Dr. Body's shown, you can use those to facilitate the discussion that you may have with your patients if you're identifying them for the new program. Just in relation to Cat4, for example, I've just done a few screenshots of some of the things you can see in your practice. You can see that if you go to the Cat4 starting point and reports, you can actually extract your active patients by going to the active patients general tab. And you choose the general tab, choose active patients, and that will show you the potential eligible population in your particular practice. You can then also clearly identify people in terms of their age range. So again, in the general tab, if you choose age range, and again, in this case, 50 to 70 years, you'll be able to select people by a 12-month date range, and that will show you the number of active patients in accordance with the RSCGP criteria for active patients that have actually had a smoking assessment done in the last 12 months. You can also then get a nice little pie graph there, which is a very useful piece of demographic information. That will actually break down, if you go into the demographic slide, smoking status, that will show you the actual status of the patients in accordance with those little colours there. And thank you. And then you can also go to a report. So if you select smoking status tab, you can also then find this report in PenCat, which will show you again the actual patients that have been identified, and it will give you some information about their smoking status. Now, just in relation to best practice, things are, oh, sorry, and then the report steps there, you can use the smoking status, you can show the percentage, as I mentioned. Thanks, Olivia, sorry. And we can go back to the next slide. And it shows the selected patient group and allows you to measure the improvement over time by comparing your reports. It's important to note that the date of the assessment only changes when modified or additional information is put in, and anyone in the age range with an assessment that more than 12 months ago is counted as nothing recorded. So double clicking on that will allow you to see those patients with the date of the last assessment in the smoking column. Thanks, Olivia. BP is a little bit different, as you'd imagine, and we'll have a screen graph in a moment. But in addition to actually finding the smoking status of your patients, you can do that in the family and social history page. And you can select the patients in accordance with them, again, being active. You go to the internal ID from the clinical page, find their smoking status, and then you can actually order them by surname and first name. And we've just got a little screenshot there of the BP best practice family and social history page. That's essentially where you're finding out information about the tobacco history of your patients. You can search by non-smoker, smoker, and ex-smoker, when they've started and stopped smoking, their method that they use, which is cigarettes. As we've heard, vaping isn't included in any of the software as far as I'm aware at the moment. And then you can also click on yes or no if the patient's actually prepared or interested to have some advice or support in relation to stop smoking, so cessation. Medical director, not dissimilar in a way to best practice. You can go to the View Patient Education leaflet to find out about smoking and quitting. By clicking on the smoking cessation intervention, discuss with your patient, this will flag whether they're interested in stopping smoking, and that's found in Medical Director Insights. You can then also click on the update address for all family members to check their address details. And sorry, so something on the way there to check details and to find out if they're members of the same family. And you can auto capitalize names to check boxes to see if everyone's in the right word type. Thanks, Olivia. Just the final takeaway I'd say then in conclusion in relation to your practice eligibility, and I noted there was a question that came up as well. You cannot currently select your patients directly in the same way as the eligibility criteria for the new program has been set out. So that's the 50 to 70 asymptomatic and their PAC history years, but you can filter by age, smoking status, and then you can use an online calculator to find out about people's smoking year history. The new program, as we know, comes online on the 1st of July. It's underpinned by the National Cancer Screening Register. So that also underpins the National Cervical Cancer, Bowel Cancer and Cervical Cancer screening programs. So what we'd encourage people to do is, if they haven't already integrated the NCSR into their practice software, thinking about the new lung cancer screening program coming on stream in July, it's a good opportunity to consider integrating your software to the NCSR now. Be ready for the 1st of July. The other thing I should say is that we will definitely be rolling out more comms in relation to what's happening with the cancer screening program. We're hoping that there is going to be some kind of public-facing sort of community-orientated publicity campaign, which will be coming on stream probably closer to the 1st of July. And we're also hearing that there may be the possibility of some of the software vendors developing online calculators which will work in accordance with the eligibility. The other thing I'd say is, if in doubt, we've got QI activity templates on our website, and obviously smoking status is PIP-QI measurement number 2, so we can always provide folks with information about that. And just before I go, I did say there was a question that came up about e-cigarettes. My understanding is that that's not included in any of the software that's currently being used. So vaping or e-cigarettes is not categorized as a sort of a smoking status currently for patients. And with that, I think I may hand over to our next presenter, who I think is Adila for Health Pathways. Thank you.
I think we might be back to me just for the localized services and pathways. It should be sharing. So before we talk about the referral pathways for the lung cancer screening program, I just wanted to talk about some of the potential challenges. And we're fortunate we're not the first country to start a new lung cancer screening program. So we've got a lot to learn from our overseas colleagues. One of the biggest challenges overseas, particularly in the US, has been about suboptimal screening uptake. So their recruitment rates for eligible participants is less than 20% across the US. And part of that is because there really isn't awareness about lung cancer screening. There's significant impact about the location of CT facilities and the costs associated, particularly in the US. But that's a consideration as well for our patients. What was great to hear last week at the Australian Lung Cancer Conference was that the UK is having a much better experience. So the UK also started a national lung cancer screening program, and they're actually getting uptake and recruitment rates of over 70% in their areas. They have taken a different approach to lung cancer screening. So they're approaching everyone at a population level who is in between their particular age range and who has ever had a history of active tobacco smoking. And they're inviting them to have this lung health check. And that really does address some of the stigma, or reduce some of the stigma around lung cancer, which is one of the big barriers for people seeking help when they get diagnosed or wanting to not be diagnosed with lung cancer, is that sense of that feeling of blame. And so by doing the lung health check, they then screen these patients. They're actually using risk prediction models to then determine who's eligible and recruit them in. Other potential barriers are really suboptimal awareness amongst our own team, so making sure that our colleagues are aware about lung cancer screening. There are concerns about the performance and the radiology performance about CT screening. So it is a particular protocol. It's quite detailed that people need to, or radiologists need to follow in terms of lung cancer screening. Often it's advised that people use computer-assisted diagnostics, which may not be the same across the board and may not be equitable between different healthcare providers. And then obviously there are concerns about the capacity of our workforce, both in the primary care setting, having the capacity to do these eligibility assessments and then manage on the flow and effects, but then also for us in tertiary care, assisting with the workup, diagnosis and treatment of these screen detected findings. So as mentioned, there will be more information coming out. This is just one of the leaflets. I think they've got 21 planned from the Department of Health in terms of how we can prepare for lung cancer screening. So there will be information designed for healthcare providers. The College of Radiology has already started educational series for radiologists who are interested in participating in the National Lung Cancer Screening Program. There are also patient materials and consumer materials that are being created by Lung Foundation Australia, which are also going through their final approvals and checks, so should be available soon. But most of the mass campaigning to people and the broader population will be in July. So in terms of the program, we spoke about, now we're really in the promoting and raising awareness about lung cancer screening and getting our practices prepared for lung cancer screening to try and reduce some of that burden when it starts in July. There will be the screening eligibility that we need to consider. All patients, whether they're eligible or not eligible for screening, should be offered smoking cessation support. There isn't any additional smoking cessation support that's been announced, so it's directing into what's locally available. Patients who are eligible, as mentioned, will then go through the recruitment process and eligibility assessment before being signed up to the National Cancer Screening Register and having their CT scans. So how the CT scans will be communication. So if the patient has a completely normal or very low risk result, then that's really the only result that both the patient and the practitioner will get the results at the same time. And the advice will be to come back in 2 years for their repeat suitability assessment and then to obtain their request for their ongoing screening study. For every other category of risk, the recommendation will be to see the referring practitioner to discuss the results. So the registrar will notify the participant to contact their practitioner, and the registrar will then notify the practitioner of the results and request that the practice contact the patient. So it's a two-step process, but the participant is getting 2 reminders to see their practitioner to organise further follow-up. In terms of the nodule management, so the scans are going to be reported different to clinical reports. It's going to be structured reporting. So at the end of the scan, there will be a conclusion that gives a risk category for the findings of the screening study. So for some people, that may be an incomplete study. What incomplete really means is that the lung parenchyma were not able to be assessed appropriately, likely because there were some inflammatory changes, or perhaps there was issues with the scan itself and the way it was performed. And what is recommended is then you get a short interval, and the radiologist will recommend that interval to allow for those potentially inflammatory changes to resolve and to then get a new baseline scan. As I said, for very low risk, there will be a recommendation just to continue on screening. Now, the risk categories for our nodule management is going to be based on the Pan-Canadian Nodule Management recommendations and a modified version of this. So this was designed for screen-detected lung nodules. It's also been validated for non-screen detected nodules, and we've just tweaked it slightly for our screening program and the biennial program. So low-risk patients who have that finding, they will be recommended to get a 12-month scan. Low to moderate risk will be recommended 6 months. Moderate risk will be 3 months. And so these 3 categories will be managed in the screening program. So participants will be recommended to see their referring practitioner to then organise for the interval scan as recommended. At the interval scan, if there is no growth that's demonstrated, then the report will then recommend the next category down. So if you had a moderate risk finding that recommended a 3-month scan, you go in, the nodule is stable, then the next scan will suggest that it is a low to moderate risk for 6-month follow-up, and so on until you're back to the 24-month CT pattern. If there is nodule growth, then you'll be recommended, similar to the high and very high risk nodule categories, to then be referred into a respiratory physician with links to a lung cancer MDT. High risk is just a high risk nodule, greater than 30% risk of malignancy. the very high risk are those masses and lymph nodes that are really suspicious for lung cancer. And so after that assessment, depending on what happens, the patient will be temporarily out of the program. If they get lung cancer confirmed, then they will go as per the optimal care pathway for lung cancer and exit the program. If this ends up being a false positive result, so there's no lung cancer found, then the patient will leave the hospital setting and go back into the screening program. There is a separate section for actionable additional findings, which we'll discuss in a little bit. But I just wanted to bring up an example of how the nodule risk will be calculated. So this is just one patient. We will be having a separate session specifically about management and reviewing nodule management for screen detected and non-screen detected nodules. But for this patient, we've just said they're 70 years old. So this is the PanCan, also known as the BROC nodule risk category. You put in their sex. It does include family history, so that was why it's relevant to include it in the referral form for the screening test. It looks at the presence of emphysema, it looks at the nodule size, and it looks at the nodule type. So was this purely ground glass or part solid or solid? Is it located in the upper lobe because there's a higher risk of malignancy? The number of nodules and any presence of speculation. And so for this patient with this part solid nodule, their risk of malignancy is about 45%, which would fall into that category of high risk, where you would refer into the respiratory physician with MDT links. So I'm just going to change tack slightly and move on to additional findings. So as we know, with any CT test that's performed, we don't just find out about the question that we're looking to answer. There are lots of incidental or additional findings, and these are just two examples, one of a hepatic cyst, another one of a vertebral crush fracture. And so we've done work looking at incidental findings, or as they're going to be known as part of the screening program as additional findings, as part of the International Lung Screen Trial. And when we looked at our Australian participants, which were over 2,000 participants, so 75% of our patients who are participating in lung cancer screening had a incidental or additional finding. So very frequent. But the important thing is most of them were not actually actionable. So actionable means clinical, potentially clinically significant, needs further assessment, as opposed to non-actionable, not going to cause this person problems, we don't need to do anything further. So when we restricted it to actionable only incidental findings, it was about 21% of people in our cohort, screening participants, who had an actionable incidental finding. And you can see there is variation between sites, and part of that may have been the differences in the population, but more likely as well, the thresholds for reporting something as actionable. For us in the ILST, there were two common incidental findings. The most common one was coronary artery calcification. The second most common incidental finding was emphysema. And that's fairly consistent with the literature internationally and their experiences, and not unexpected given our patient population of older patients who have a heavy active tobacco smoking history. I just wanted to touch on the incidental coronary artery calcification, because we have had a look at it in our screening study population, and it's one of those areas where, as we've just discussed, it's very common to find incidental coronary artery calcification in our high-risk lung cancer screening population. But also in the NLST, so the largest US lung cancer screening trial to date, the actual leading cause of death was cardiovascular disease. And so it's a significant opportunity for us to improve healthcare outcomes for our patients if we recognise that there is coronary artery calcification on our CT, and we do incorporate that into our cardiovascular health assessments. Now, in our study, not a bit disappointing, but perhaps not unexpected, actually, there was still a proportion of patients, despite it being in the trial protocol, who did not see their primary healthcare providers for the results of their CT. So a number of patients, even in the severe, were unaware that they had coronary artery calcification, and these are all patients who do not have a known history of coronary artery disease. Of that, most patients were not notified about the coronary artery calcification because it was in the body of the report, although that decreased as the severity got higher. We also found that there was some variable downstream investigations and management of the coronary artery calcification. So there really is a significant opportunity to find that coronary artery calcification and use it as an opportunity to have a discussion with our patients about their cardiovascular health, to use the Australian Cardiovascular Risk Disease Calculator, and for moderate and severe coronary artery calcification to help us kind of up stratify their risk in that assessment. So the Australian version of the additional findings management guideline is still being finalised, but it will look similar to this one here, which is from the American College of Radiology. And what they've provided is a quick reference guide for common incidental or additional findings, and they've separated it by system. So this is in America. They looked at, for instance, the lung, and they've said if there's mild or subsegmental atelectasis, that's okay. Nothing needs to happen. Similarly, with thyroid nodules, we know that they're very common. You don't need to do anything about them if they're less than 15 millimetres and look benign. But there are other findings where we do need to do further follow-up. So specifically for interstitial lung abnormalities, that needs the clinical assessment and a discussion about whether or not this needs to be further investigated. Similar with, more suspicious looking thyroid nodules. So the College of Radiology is actually producing similarly detailed guidelines for us to use as part of lung cancer screening. In terms of the referral process, and I know we're going to have a discussion about the healthcare pathways next, but I just wanted to introduce a new program that we're starting at the Royal Melbourne Hospital, which will start in the middle of the year. The program is still being finalised, and so hopefully with this next seminar, we'll actually be able to share with you how we're going to structure in the referrals to this new program. But we really want to be able to help support our primary care colleagues in lung cancer screening, and so that's the purpose for starting this educational series. And at the end of this seminar, there'll be an opportunity to give us some feedback and suggest other topics that you might be interested in. So I do welcome any suggestions. We're also going to be starting a new lung cancer screening clinical nurse consultant role, which will be able to offer remote support to yourselves. So you can call in or leave a message or send a message to us, which will then be able to provide additional support if you had any questions about your patients in the community or screening eligibility or something that you wanted to discuss that was related to lung cancer screening. We can also help with helping direct patients to the clinics that they need to go to at the Royal Melbourne Hospital. So we will be starting a new, we have an existing lung nodule clinic, but we're going to start a second lung nodule clinic that will be nurse-led. And we're also going to be starting a physician-led lung cancer screening clinic so that we can see some of those higher risk nodules, but also see some of those additional findings, such as interstitial lung abnormalities or severe emphysema that you feel would warrant a respiratory review. So with that, I'd say thank you, and I might just hand over to the next speaker.
Hi everyone, my name is Adila London and I am a program officer with Northwestern Melbourne Primary Health Network, and I work with the Health Pathways team. I'm here to tell you what Health Pathways is, how we develop any pathway, and how you can access the pathways. So Health Pathways Melbourne is a collaboration program run by Eastern Melbourne Primary Health Network and the Northwestern Melbourne Primary Health Network. And it is supported by local GPs, hospitals, health networks, community health providers, and other health professionals. So it's a single website that provides clinicians to access a comprehensive collection of locally relevant clinical information and guidelines that are designed to support general practitioners and other healthcare providers in delivering consistent and evidence-based care to their patients. They include medication information, referral information, and further resources, which can be used at the point of care. As an example, if a GP is new to an area and they're not very familiar with the local assessment, management, and referral criteria, they can jump onto Health Pathways and have a look at the guidance for their catchment. In addition to that, they will have resources that can be informative for the GPs and the patients. This slide shows you the main page with the latest health alerts from Melbourne that are sent to us by the Department of Health, any pathway updates that we have, and then there's a snapshot of the table of content on the left-hand side to show you the different conditions that Health Pathways cover. The table of content can also be used to navigate to the relevant condition or by using the search function on the top of the page. And should you ever have any feedback for any pathway, we encourage you to send feedback via the blue bottom button on the bottom right. If you have any questions that are non-clinical related, myself or anyone from the team are able to answer them, we will do so. If not, we will be sending through the questions to our GP clinical editors. This is a little overview of the relevant clinical and referral pathways that we have for lung cancer. All of the pathways, they undergo full review and are roughly updated every 3 years with the help of a clinical working group, which consists of a GP clinical editor, GP reviewers, we have subject matter experts, pharmacists, and any other relevant stakeholders. The referral pathways, they consist of service information that includes criteria for referral, any inclusion or exclusion criteria, any referral forms, and how you were to submit that referral, if it's via fax or email or by e-referral. And should there be any updates to any of the referral information, prior to that 3-year review cycle, we will always jump on and edit this information so it's up to date. At the moment, we will be creating a lung cancer screening program pathway, and we have currently scoped how this page will look like. We will have an assessment section that would include the eligibility and suitability. The management section will inform of the risk categories depending on the findings, and the referral section will be according to the guidelines that will be released. We may potentially create a separate pathway for the incidental findings from lung cancer screening, or include this information in one pathway. We also have a CPD tool once you've logged into Health Pathways. So whenever you jump on use Health Pathways, the tool will be recording the time spent on each pathway. And say after a week after using Health Pathways, you can jump on here, you can click on the button to create a CPD report. If you were to create a CPD report related to respiratory, you can select all of the pathways that you've accessed and just hit create a CPD report, and it will generate a PDF report for you that you can download and use towards your CPD hours. In terms of accessing Health Pathways, you can either use this QR code or just Google Health Pathways Melbourne. You need to sign in or register. If you haven't used it before, go ahead and register. You will need to provide your name, your professional role, and information about where you're currently working, which will give you access to Health Pathways. Please send through any questions if you were to have any. Thank you, everyone, and I will hand over back to Dr. Asha Bunny, I believe.
Great, thank you. I think so that's it for the formal part of our seminar series. We were just hoping to do some poll questions if we could bring that up. The purpose of that really is to see, one, how useful was this session, but two, to actually plan for future sessions. So the plan is to do a few more of these webinar series, some of which will be a bit more interactive, but we're interested to find out what topics you're actually interested in learning about and discussing. So we're planning to talk about lung nodule management, some of those additional findings in a little bit more detail, but we'd certainly welcome any feedback. Olivia, are you able to? Perfect. I think that should come up similar, same as last time. You just need to scroll down. There's 4 questions. And then we will have maybe a few minutes to complete those, and then we'll open it up to any questions you may have.
And when you've completed the poll, think about the questions you'd like to ask, either put them in the chat or you might be able to unmute if we haven't got that many people. So in the chat box or raising your hand in the reactions.
It was a bit of a whirlwind tour through the lung cancer screening. So any questions you might have about any of the topics we've touched, or if you have any other questions about lung cancer screening. We also have Renee Manser, who's one of my colleagues at the Royal Melbourne Hospital, who's another respiratory physician with a PhD in lung cancer, screening and works in our lung oncology clinic. He's also here to help with the questions.
I think we've probably got to the number that are going to be doing this.
Yep, okay, I'll just end up. Pause ended. Excellent. It was just a comment from, is it Umu Ruff? Did you have a question?
Yep. So what happens to patients with symptoms for lung cancer? So if someone's symptomatic, what happens? Do they get a CT through what means?
Yeah. So that's not through screening, and that will be as part of workup for lung cancer. So if someone's symptomatic, they can get the CT for investigation of those symptoms, and then a referral to our lung cancer or lung nodule clinic, depending on what those findings are. But the presence of symptoms would mean that they're not eligible for the screening pathway.
And that's the same as with breast screening. So people can get their mammogram when they're asymptomatic, but when they are symptomatic, they don't go through breast screen, they go through conventional pathways. Anybody else got questions? I've got one, Asha. So the incidental findings of the coronary artery calcification, it was surprising the number of people who didn't go back for the results, didn't return to their GP for results. So are there any learnings from the other studies on how we maybe need to pre-frame or set things up that the patients will come back to the GP?
Yeah, so one of the commonest reasons, just anecdotally, that patients told me that they had gone back to their GP was they thought that the GP would call them if there was something that they needed to do. And that was despite it being very clear in the consent form that they signed and the processes and the advice from the screening staff that you needed to go back to your GP. And I think that really highlighted to me the importance of informed consent, whilst it's not an official form that you need to get the patients to sign. When you are enrolling people into the National Lung Cancer Screening Register, that you make sure that they understand that if they are not getting an all clear tick, then they need to come back and see you to discuss the results.
And do the results go up to My Health Record? So
I
if they
think
go
that
to a
My
different,
Health,
yeah,
it's
because if they
linked
go
to
to
the
a different
screening
GP,
register.
yeah.
It's linked to the screening register, so it will be, I believe that is linked to the My Health record, that the pathology, and the CT results should go up there. And then the cancer screening register for that patient.
So has anybody else got any questions about, maybe how the practice end of things work, or finding patients? Any other questions, please? Asha or Renee, are there any things that people have been asking you that might not have been covered tonight? So any frequently asked questions that we haven't covered yet? Renee or Asha?
Thanks, Sue. I'll just step in, but I think it's probably hard to sort of think about the things that are going to arise until it happens in practice. But I imagine some of the problems that might arise would be, when people come along who aren't eligible for screening but want to access screening, and how you have the discussions around that, and how you reassure people that they're about their lung cancer risk. The eligibility criteria for this program are quite narrow. There is probably evidence for screening in people who, the screening studies included people with a lower risk, if you like, but all with a history of active tobacco smoking, but perhaps less pack years and have given up more within the last 15 years, for example. So there's some people may come along and question why they won't be eligible for the program. And I guess just to be prepared for some, to give some answers about that, and, prompt people to make sure that they do report any symptoms early, and that, early early detection with any symptoms is still very important in that group of people, but that they won't be able to access the funded CT scan. So there's some education around the symptoms of lung cancer and early detection is probably useful. The other issue, just to touch on, was about the eligibility, which you mentioned that if they've got symptoms, they should go down a diagnostic pathway rather than a screening pathway. But also, if they've got symptoms, the other thing is if they've got symptoms of a cold or a flu or something like that, it's also very important not to do a screening scan at that point, because it's likely, and that's one of the things that I think is mentioned in the program guideline, because it's likely to pick up some inflammatory or some other changes, which, will be not lung cancer, but will warrant further scans. So in most of the screening studies excluded that group of patients. And so you'd recommend, look, come back, we'll do the scan in sort of 8 to 12 weeks once all things have settled down. So that's one other point that I'd make, I think.
Okay, thank you. So we have, and remembering that if somebody chooses to get screening when they're not eligible, unless there are symptoms, it's not generally got a Medicare rebate. So there are like executive programs where people who are asymptomatic get screened. So there is, the option the patient could pay for it and self-fund. Now, there's a question about the patient resources that will be coming out. Will there be multiple languages, multiple translations? I think in our previous discussions that is going to happen, but Asha, can you fill us in on that?
The Lung Foundation has said they're going to produce a wide variety of linguistically diverse materials for patients about screening.
And we have another question, which so the program excludes vapes, so that's it's only tobacco and cigarettes. But there's a question about item numbers and
the only thing I'd say as well is it doesn't, it just doesn't account for it in terms of the risk. So in order to calculate the risk, it's really about that person's cigarette smoking, not the vaping. Although we do acknowledge that vaping is probably, going to put the person at an increased risk. It's just not.
Yeah, but they won't have been doing it for over 10 years because they haven't really been
No,
around
so
that.
if you have someone who also smokes a few cigarettes, you could take this 5-year smoking history from that.
Yeah. So with regard as a GP, there have been different rebates for different things like a heart health check and health assessments. If someone's being assessed for the lung cancer screening program, is there a special item number for that, or is it just a normal consultation? Do we know at this point?
It's a normal consultation is what the guidance has been so far. So the only additional lung cancer screening item numbers are for the actual CT scans. And I believe that that's still being finalised. I don't think the formal item number and the exact rebate amount has been published, but Renee, correct me if I'm wrong.
Okay, so it'll be a time-based or normal complexity as a GP. So
Yep.
including it in the holistic care for a GP, it might be one of the many things that you cover in a GP consult. Any other questions that people have got for us? So there's just a comment, I think more, why isn't a self-enrolled questionnaire like breast screen that GP can, sorry, it's a bit hard for me to read that one.
I think the reason that it's not just an automatic questionnaire for patients is because lung cancer screening, there is that complexity in terms of all of the extra findings and the process that's involved, where some pre-screening counselling would be really useful to making sure that the patient understands what exactly they're signing up for and the risks of participating in screening, as well as the benefits. They're also hoping that we use this opportunity to modify risk. So that one of the biggest determinants of your eligibility is your active tobacco smoking history. And so using that entry into screening as an opportunity to modify risk as well.
Thank you. And so we've talked about using practice tools to case find. So could somebody put out in the waiting room their own little personalised questionnaires for patients? There's something that a patient practice could do themselves, just a bit of a health survey while patients are waiting. And, I think it's also being aware of the calculating the pack years. So some patients might be able to do that, some might not, but you could ask the questions there if you wanted to do that as an initiative in your own practice.
Yeah, absolutely. And screening, do you actually meet the eligibility criteria would be a great way if you could send out a questionnaire and get those responses back. It would save you a lot of time rather than individually asking every patient during a consult.
Yeah, some practices have a theme for the week, check people's vaccination status or check people's blood pressure or weight, and have little post-it notes on the computers or little things that to remind people. So, it could be something that you and your practice manager or practice nurse have a think about. Well, how are we going to update people's smoking history, and how are we going to make sure that we are able to easily extract that data? So that might be something to think about over the next month or two to add into your updates of your histories as you're going through. Okay, and any of the PHN staff got questions, as well as the last, we've got a bit more time. So if anybody else, even on the PHN staff, have got questions, we'd love to hear them before we wind up. And anybody who hasn't renamed themselves, if you're wanting to get CPD points, we need to have you identified as something other than iPhone, so we can know that you are registered and actually here on the call. Okay, so it sounds like we have got everybody curious, but you've satisfied all their curiosity for the moment, Asha, and thank you very much. Now, what we just need to, the session conclusion. That's great. Thank you, Olivia, for keeping it up. So you'll be getting an email, or you can actually also scan this QR code. And if we have your actual name for the details, you will be getting an attendance certificate and those CPD hours uploaded. But if you haven't got your full name there, we won't know that you're really here. And this will actually be up on the Northwest Melbourne PHN platform on YouTube, where they have their CPD and webinars. So if you've got colleagues who'd like to look at that, you'll be able to look at it on those resources. Is there anything else that we need to attend to?
And I think only just to encourage you again, so in your feedback, if there's any particular areas or topics, please do put it in. We are very open to the suggestions.
Yeah, and there will be, keep your eyes open. We were looking at having another session in a few months' time. So there will be some more as more of the programs being updated and revealed what will be happening. So we can keep you up to date. You can start thinking about how to get your practice ready and how to make the best of this lung cancer screening program to work for you.